welcome everybody and just give people a few more minutes to come online. It's terrific to be able to welcome everybody to this webinar. Our webinars are one of the great member benefits that ANZ offers. And I'm going to introduce Kiera Buchanan shortly, who will be presenting today. But just let me make sure that everybody's fine with the technical things. And by the sound of it, it seems like people have pretty much got this worked out. And so ideally, you want to be listening to the sound through your telephone. And to prevent there from being any feedback, you want the little microphone sound icon, which is down at the bottom left-hand corner, to have a cross on it. So if it's got a tick, you should just click on there, and that will turn that mic off, and that will stop interference from happening. Another thing that sometimes happens is that you get the screen freezing, and if that happens, what you want to do is refresh your screen. And to do that, you will see right at the very top right-hand corner, there's a red X, and you go up to that, and you click on that red X in the top corner, and then an orange button will come up to reload the conference browser, and that will reload the screen. And so if you have any other technical difficulties, you can phone the support line *0 of the number that you have in your email about this. That's the technical things. It looks like people have pretty much got that worked out. So I hope that there are no major problems. You can always type in if you've got a real major problem. Jeremy is on the line, although you can't actually see him, and he might be able to help. Now, another thing that I just want to highlight about these webinars is that we do want them to be as interactive as possible. And so what we encourage you to do is to write down in the bottom corner where it says type message here, your questions as you go along, and I'll jot them down, and then we'll answer them at the end. So Kiera will address questions at the end of her talk, but you can write them in as we go, and I'll try and keep track of them. If you think that I might have missed them in some way, you might want to make a note of them too, just to make sure that they don't get ignored, but I'll do my best to keep track of them, and then at the end I'll ask Kiera to respond to them. So let's move on now. I want to give her as much time as possible to discuss this very interesting topic. Kiera is a clinical and health psychologist, as well as the founding director of the Centre for Integrative Health, which is a multidisciplinary clinic devoted to eating and weight concerns in Brisbane. So she's very much involved in the clinical side of things, but has also conducted research in this area. So she's a great person to bring these two clinical and research areas together to talk about this important topic. And we know that this is something of particular interest to our members, not just because we have already a large number of people online, but in recent surveys our members have indicated that this is really important. So we very much value your contribution, Kiera, and thank you for the webinar you're about to present. So over to you, Kiera.
Great, thanks Susan, and thanks Chans as well for giving me this opportunity to get the conversation sort of started around the shared space as well as the differences between obesity and eating disorders. So if we kind of jump right in, or actually sorry, before we jump right in, something that I do just sort of acknowledge is that there are plenty of people in both the fields of obesity, health at every size, and eating disorders, who are actually all far more experts than what I am. So today I'm just hoping to sort of, like I said, facilitate a little bit of a conversation in the field, but I want to make a particular acknowledgement and say thank you to the many people who have added advice and pointed me in the right direction and contributed in some shape or form to this webinar today. So you don't need to be an expert in the field of obesity or even a clinician working in the field of eating and weight concerns to be really familiar with the statistics around obesity, because it's something that's constantly in the news and we're always being told about. But for those of you who aren't aware, within Australia, the rates of obesity are now 1 in 5 men and 1 in 6 women, and these rates have more than tripled since 1980. Simultaneously, though, our rates of eating disorders are also at an all-time high. So sadly, the prevalence of disordered eating behaviour in youth aged over 15 has actually more than doubled in recent years. And not only do we have higher rates of eating disorders and subclinical eating and weight concerns, but we're actually finding people presenting for treatment for an eating disorder at younger ages than ever before. We're also finding more men presenting, and we're finding a larger number of people at an older age as well. So there's been a real increase in even postmenopausal women presenting for treatment with eating disorders. So we've got the rates of obesity and the rates of eating disorders at an all-time high. And interestingly enough, the presentation that has risen more quickly than either eating disorders or obesity is comorbid eating disorder with obesity or obesity with eating disorder. So the rates of comorbid obesity and eating disorders have more than tripled in the last decade. So we're finding now that 1 in 5 people with obesity present with disordered eating, and this isn't just binge eating disorder either. So in fact, almost 40% of people who presented for treatment in one particular study were found to have previously met criteria for either a BMI that put them in the range of being overweight or obese. So we're starting to see there's actually quite an overlap, and we're seeing the prevalence of both rising simultaneously, which kind of starts to lend to the conversation of how much do these two have in common, or are they both very different? And so traditionally in the past, we know that both obesity and eating disorders have been conceptualized as very separate conditions. However, recent research, as well as a number of physician papers, have started to discuss the importance of considering issues of obesity and eating disorders simultaneously. However, this opens a whole can of worms. So there's a lot of people, obviously, that are quite opposed to this idea. And so it's a topic, I suppose, that I think personally is deserving of very thorough investigation, weighing up the pros and cons of considering the two simultaneously. So in today's webinar, just to give you a bit of an overview, I'm going to try not to get too bogged down in any small details. As I said, there's people in the field that are far more expert than what I am, but instead I'm sort of just hoping to take a bit of a broad brush approach and start to think about where obesity and eating disorders might be similar, where they might differ from one another, and what the two fields might be able to lend to the treatment and also prevention of both areas. So we'll start by looking at what they have in common and where they differ in terms of their definitions and diagnostic criteria, their physical and mental health implications, the onset, treatment and prevention approaches, and the evidence base for the two of those, and then start to kind of open up a bit of a conversation around possible avenues for change in a hope of sort of forging new pathways which see us sort of being more effective in the prevention and treatment of eating and weight concerns across the population. Okay, so if we kind of get started with the diagnostic criteria. So I don't want to kind of get bogged down, like I said, but a really important difference, I suppose, is that obviously eating disorders are mental health condition, whereas obesity is classified as being a medical condition. So eating disorders aside, when we look at what constitutes something to be a mental health condition, we actually take into account a lot of different things. So we consider what's going on for the person in terms of their behaviour, their cognitions and their emotions, whether this is having a significant impact to their level of functioning in a number of different areas. We think about the severity and the frequency of this pattern of presentation. And we're also really sensitive to taking into account the individual. So trying to take into account their developmental stage, their culture, their sex, and whether this might account for what we're seeing in this person, better than simply broad brush diagnoses. And then obviously within our diagnosis of eating disorders, we have a number of sub-diagnoses. And as you will all be very aware, our reasons for doing this is it's quite helpful in sort of forming how we might best treat these presentations, prevent these presentations, and it's helpful for us in understanding how effective we are and in informing research. Now, something that I just wanted to really draw our attention to is obviously there's been a number of revisions to the diagnoses of eating disorders and the DSM within itself. And something that we now understand and we really take into account in the diagnosis of eating disorders is that BMI itself is no longer a diagnostic criteria. So instead of saying someone needs to have or not have a particular BMI to meet criteria or not meet criteria for an eating disorder, we talk about someone's weight in amongst a whole host of other things relative to that individual. So we know that now as clinicians that someone can be of a low weight subjective to them, even if that weight isn't classified objectively as being low weight. So it's just an important note to kind of keep in mind as we move forward through this presentation. And so yes, we can't tell whether or not someone has an eating disorder simply by looking at them. Now when we look at obesity, obesity is classified as being a medical condition, not a mental health condition. And when I sort of tried to delve into what constitutes something to be a medical condition, the ICD-10 outlines that a medical condition is the presence of disease, illness, or some sort of abnormality occurring in the body that impairs functioning physically, socially, or psychologically. So again, it goes into a little bit of detail around what constitutes a medical condition. However, when we look at the diagnostic criteria for obesity, it is a BMI of 30 or above, full stop. So we don't look at whether there is disease, illness, or abnormality for this particular individual. We don't look at patterns of behaviour pertaining to a behaviour, cognition, or emotions. We don't consider whether there are any impairments to functioning, and we don't take into account the individual, so their developmental stage, their culture, or gender. We just flat out give a diagnosis of obesity to each and every person who has a BMI over 30. We also know that BMI is quite unreliable in lots of different areas, but particularly among those weight training athletes, Asian populations, older adults, children, and people with muscle wasting conditions. So unlike the diagnostic criteria for eating disorders, in my opinion, the diagnostic criteria for obesity, it doesn't really do anything meaningful to guide treatment. It simply tells us that a person is fat, has a BMI over 30. It tells us nothing more than that. So if we start to look at what some of the physical and mental health implications associated with both of them are. So within eating disorders, they are primarily a mental health condition, but they are associated with both acute and chronic risks, or acute and chronic medical or physiological conditions. And this is not contingent to weight or BMI. So we know that all people with eating disorders are at risk of a host of chronic diseases. However, I suppose more anxiety-provoking for those working with eating disorders is the acute risk. So regardless of someone's body weight, some of the different implications involved in, say, anorexia, bulimia, put someone at acute risk of cardiac arrest and kidney failure. So we know that although eating disorders are a mental health condition, they also are associated with chronic risk, but more anxiety-provoking for us working in the field are the acute medical risks. When we look at obesity, so the physical health implications. So while we can say that everybody with an eating disorder has a mental health condition, and everybody with an eating disorder has a risk of chronic and acute physical illness, we can't actually say that for everybody who is obese. So the literature actually tells us that 51% of people who meet the diagnostic or the BMI criteria for overweight are actually metabolically healthy. And 31.7%, so nearly 1/3 of those who meet criteria for obese are metabolically healthy. At the same time, 23.5%, so nearly a quarter of people who fall within the healthy weight range actually aren't metabolically healthy. And when we look at this study over here, which is really fascinating, so this is the Lancet study in which it was a sample size of 900,000, and it was a longitudinal study. And what we've got along the bottom here, I hope that everybody can see that okay, is the BMI of people. And then what we've got along this axis here is the rate of death per 1,000. With the purple lines being female or boxes, sorry, and the black lines being males. I suppose some of the important things to really draw your attention to here, or maybe perhaps first I should just sort of familiarise people with the BMI cutoffs. So we say that someone between a BMI of 18.5 to 25 is healthy. So below 18.5 is underweight, and over 25 is overweight, and over 30 is obese. So keeping that in mind, when we look here, get my little pen back. When we look here, here, so the rate of mortality in people who have a BMI of around, what would we say there, 17, is the same rate of mortality as people with a BMI of around 37, 38. And remembering that we're saying that people then who are just off the cusp of fitting within the healthy weight category have as high a risk of death as those that are actually within the obese range. And we see the exact same pattern with men as well. The other thing that's really interesting is this line down here is meant to indicate kind of what they refer to as that sweet spot. So the BMI that actually had the lowest levels of death. And keeping in mind as well, this was actually accounting for things such as smoking and alcohol consumption, a whole host of other factors. And what we have here with both men and women, the lowest rate of death actually occurs at a BMI of 25. And that's right on the cusp of being overweight. So we're saying that the people that live the longest are actually those within the overweight category. So not everybody with obesity is unhealthy. Then when we start to look at the mental health implications, so as I said, we can assume that every single person with an eating disorder has a mental health condition because an eating disorder is a mental health condition. And not only do they have psychological distress and body dissatisfaction that is part of the eating disorder, but there's also a really high level of comorbidity. So 45 to 86% of people with an eating disorder have depression, 64% have comorbid anxiety disorder, 58% have a personality disorder. And I suppose of most interest is to note that the mortality rate for suicide amongst those with an eating disorder is the highest of all psychiatric conditions, with a nearly 25% mortality rate for suicide amongst those with eating disorders. However, that's not the case within obesity. So some people who meet criteria for obesity do have psychological distress, but not all. Some do have rates of weight dissatisfaction, but not all. And in fact, quite a large population study was able to say that there was no difference in psychological distress based on different BMI category. And when we look to those who are obese in terms of distress related to weight, it's actually those who have internalized the thin ideal and the weight stigma who report high levels of body dissatisfaction and psychological distress. So within those who have levels of body dissatisfaction and psychological distress, so within those who are obese but do not have that internalized weight stigma or thin ideal, they actually report no psychological distress. So basically, the point I'm trying to make here is that eating disorders do have always a host of mental health implications, but obesity does not. And in fact, it's not people's weight that causes them distress within the obesity field. It's the attitudes of society that they have also internalized that is the source of their distress. So when we look at onset, and as I've said a few times now probably, I'm not going to get too bogged down in fine details here because I can point you in the direction of plenty of researchers and papers who are able to kind of cover each of these individual topics in far more detail than I am. But some of the points that I'm wanting to make is that we now know that there is a genetic predisposition for eating disorders and there's a genetic predisposition for obesity. And we've come such a long way in the field of eating disorders, and that we acknowledge that it's not someone's fault. Developing an eating disorder is not just a choice. There was a genetic predisposition along with a whole host of other factors. And it's actually the same case with obesity as well. So we're actually seeing that some people are just genetically predisposed to developing obesity. We know that everybody, but particularly those with eating disorders and those with obesity, are both negatively influenced by socio-cultural messages about the thin ideal, dieting, weight loss, and weight stigma. So in terms of environmental factors, some of the shared risk factors for developing obesity or developing an eating disorder include having been the victim of weight-related teasing, receiving concerns about someone's body weight or shape, family talk about weight. Being overweight as a child is a risk factor for becoming obese, we know that. However, being overweight as a child, you're also at risk of developing an eating disorder. The level of media consumption is a risk factor for both, again, as well as the internalization of the cultural ideals. So both eating disorders and those who meet criteria for obesity share a lot of risk factors in terms of environmental factors. Having a weight concern, body dissatisfaction, an overestimation of weight, depression, or a lower quality of relationships is a risk factor for developing an eating disorder and is also a risk factor for developing obesity. However, a really important difference here is that everybody with an eating disorder has some concerns around weight and shape and has psychological distress. However, these aren't always involved in a presentation of obesity. And dieting. So we know that dieting is one of the biggest factors implicated in the onset of an eating disorder, with adolescents who diet having more than 18 times the likelihood of going on to develop an eating disorder. However, youth who diet are also shown longitudinally to gain more weight over time than youth who don't diet, and they're also at a higher risk of going on to develop obesity. So we know, and we're not entirely sure why, but we know that when some people go on a diet, they have a really high risk of either ending up with an eating disorder or going on to develop obesity. So we know that both eating disorders and obesity, although they have a lot of differences in terms of the predisposing and perpetuating factors, they also have a lot in common. And the main thing being that they're both a complex interaction of genetic, environmental, psychological, and behavioural factors. So now looking at the treatment approaches for the two. So obviously we have different types of treatment depending on whether someone presents for anorexia, bulimia, or binge eating disorder. However, we also commonly in the field look at what all eating disorders have in common. And this is Chris Fairbairn's trans-diagnostic model, which illustrates the shared pathology among all eating disorders. So we say that everybody with an eating disorder has an over-evaluation of weight and shape, has some form of trying to manage their weight or control weight or prevent weight gain. And then depending on, this is where the different diagnoses come from, that can lead to significant low weight relative to that individual, binge eating and purging. And that this pattern of behaving, I suppose, are sort of also influenced by negative events and emotional distress. And so we sort of take into account the complexity and the multiple factors involved in the onset of eating disorders in treatment. And then treatment aims to address all of these. So we look at helping the person value themselves more in terms of their shape, in terms of their intrinsic self-worth, external to weight and shape. And we teach them about media literacy and how to kind of manage some of those ideals. We look at changing their behaviour in a more healthy way, and we help them develop different ways of managing their emotions and improving interpersonal functioning. So treatment can be quite in-depth because it's sort of matched to presentations that we understand as being quite complicated. So as I've said as well, obesity is also quite a complex interaction of a whole host of factors, both occurring within the individual but also external to the individual. So there's all of these different things that can be involved in the onset and the maintenance of obesity. When we look at the treatment for obesity though, it basically just focuses on two things: eat less and move more. So we don't take into account what a complex interaction of different factors are. We just say that for everybody with a BMI over 30, they all need to do the same thing. And so then if we look at how effective we are in the treatment for both of those, the treatment effectiveness for eating disorders is growing, and it's really quite encouraging. There's definitely room for improvement. However, the meta-analyses state that effectiveness in recovery from an eating disorder can range from 40 to 60%. And we also commonly have a lot of people report secondary treatment gains that weren't a part of treatment. So as well as maybe recovering from their eating disorder, individuals commonly cite things such as improved self-esteem, better quality interpersonal relationships, and a whole host of other different things. We know that do no harm is one of the many principles that we abide by in the treatment of eating disorders. And in the search that I did and the research that I could find, there's no harm reported in the treatment of eating disorders. And our relapse rates are reported to be up to 33%, or a more positive way of looking at it, less than 33%. So not perfect, lots of room for improvement and for growth. However, we know in summary that people with an eating disorder have a really realistic chance of recovery, especially if we intervene early. And at an absolute minimum, people who undergo treatment can expect substantial improvements. Unfortunately, the picture for the treatment of obesity is very different. we have a 3% effectiveness rate. So 97% of people who do lose weight regain the weight back at 2-year follow-up, with 2/3 of those people regaining more weight than what they initially lost. So we don't do a very good job of this whole idea of do no harm, because not only are we not very good at treating eating disorders, obesity, but in lots of cases we make the situation worse. And those who have undergone a weight loss intervention often report feeling worse about themselves psychologically as well. So report feeling like a failure, not being in control of their life, a greater sense of hopelessness, and a reduced motivation to actually work on improving their quality of life. And sadly, despite all of the focus and the research on improving prevention and intervention approaches, we've actually made no advances in this area. Now, I don't want to get into this in too much detail, but something that I really did want to draw people's attention to is why weight loss interventions don't work. And again, I'm sure there's plenty of people that are actually online right now who are far more qualified to comment on this than I am. However, the general explanations for why we have such low effectiveness for weight loss generally center around blame and discrimination. So we tend to say things like, oh, they just returned to their old ways, or oh, they didn't actually get on top of their underlying issue. So when we look at why treatment doesn't work, we blame the individual, and we go back to making some of those really unhelpful and inaccurate assumptions that this person has obesity because of their psychological issues. However, when we look to the medical literature, it actually tells us a very different story. So that we can see that the body actually makes a whole host of hormonal adaptations after weight loss that see a person feeling less full and more hungry. So we can see that biologically the body is really resistant to weight loss and to maintaining weight loss. And as well as some of those hormonal adaptations, there's metabolic adaptations as well. So following weight loss, there's a reduction in someone's metabolism, which the person is consistently fighting against. Basically, the point I'm wanting to make here is that the difficulty in keeping off weight actually reflects a biological issue as opposed to a pathological one, or one pertaining just to willpower. So I suppose there's room for improvement in both. However, there's some really big differences in the way that we go about approaching eating disorders and obesity. So treatment's very different, rates of relapse and recovery is very different. There's more positive implications associated with the treatment of an eating disorder, whereas there's far more negative implications associated with the treatment of obesity. And also our response to treatment failure is very different. So in the field of eating disorders, we try and maintain an attitude that recovery is always possible. However, when someone is really just not faring well with treatment, we sort of really consider that and are sensitive to that, and we think, how can we help this person to live well? How can we manage the risks associated, but really facilitate this person in living the best life that they can? That's not at all the approach that we take for clients with obesity who keep failing at treatment. We kind of just keep banking about the fact that they need to lose weight, with no consideration at all as to how we might help this person to live well. So prevention approaches. So there's quite a body of research that is really promising around preventing eating disorders. And eating disorder prevention programs focus on enhancing the protective factors that promote resilience to onset and reducing the risk factors. So it includes such things as enjoying physical movement and appreciating and respecting the body, connecting with people in a meaningful way and helpful ways of expressing emotion, developing a healthy relationship with food and a host of healthy eating behaviours such as having family meals, eating breakfast every day, not skipping meals, media literacy, and also emotional regulation skills. And the results around how we do with eating disorder prevention, particularly in school-based meta-analyses, is actually really promising. Now, this is quite an exaggerated illustration of what obesity prevention looks like. But even if these aren't the campaigns that we're using in Australia, they're still the same underlying messages that we're giving. And they're messages that really focus on discrimination and weight stigma. And they're really not all that effective. And analyses have shown this. So weight discrimination has actually been shown to not help people lose weight, but make them feel less confident and less likely to engage in health practices, including exercise. And actually, in one review in which they interviewed obese individuals after they watched a whole host of different obesity prevention advertisements, not just ones as extreme as this, everybody who viewed them actually reported feeling worse about themselves, feeling quite depressed, feeling demoralized, and feeling more demotivated to make any positive changes in their health practices. So, I guess when we're also not all that fantastic at preventing eating disorders because the rates continue to escalate at a population level. However, when we look within subgroups, but there is really good results to suggest that we're able to prevent individuals at school-based levels and at individual levels. And to give you a bit of a summary around eating disorder prevention, we haven't reduced rates of obesity at population, group, or individual levels. We haven't actually seen any improvements in physical health, no improvements in mental health as a result of these prevention campaigns, no increase in health behaviour, and no improvements in quality of life or well-being. And in fact, it's actually been quite the opposite. So we know that people who engage in a weight loss intervention actually gain more weight than they lose, so it's a better predictor of weight gain rather than weight loss. And although there's quite a fair bit of contention around whether or not obesity itself is a health risk, what we actually know is that the weight cycling associated with dieting is actually directly implicated with the onset of illness and disease. People who are exposed to obesity prevention campaigns report feeling worse about themselves. As I mentioned before, it demotivates, not motivates, participation in health practices. And we have people feeling more discriminated, stigmatized, and isolated as a result of their campaigns. So not only are they ineffective, but they're counterproductive. And a few other points, and I just don't mean to get too much from my milk crate about the issue, but weight isn't a behaviour, so it's not, our weight loss interventions aren't appropriate behaviour-based interventions. It actually also detracts from health in a broader sense. So we have a whole host of people now that are so hung up on being unhealthy because of their weight, when we've completely disregarded that health is actually physical, psychological, and social. And in fact, social health and social connection is actually a really good predictor for health and longevity. We have an increased rate of eating disorder onset, and they're actually finding in schools and even preschools that young children are fearful of gaining weight because they know how bad it is to be obese. So we've actually done very little for preventing or targeting obesity, and in fact we've probably contributed to the onset of disordered eating and body image concerns. Another thing, I suppose, us getting so focused on obesity prevention has the kind of potential to misinform medical assessment and treatment. There is research that supports this. And we know that doctors, without sort of kind of wanting to pick on any particular profession, are less likely to sort of really investigate potential for chronic disease in those who are of a lower weight because they simply look healthy. And at the same time, we know that those who are overweight or obese, there's less likely to be a thorough investigation of what's going on for them to explain their medical concern because it's simply assumed to be a result of their weight. So when we treat people medically based off their weight, we miss those that are underweight or healthy weight, assuming that they're healthy. And we might also miss something that's going on for someone who's overweight or obese because we're so fixated on them simply needing to lose weight. And it's actually a barrier to recovery in eating disorders as well as health-seeking behaviour. So we know that people with an eating disorder do have a fear of gaining weight. That is part of their diagnostic criteria. However, part of that fear of gaining weight is actually well-founded. They have these concerns about becoming fat and becoming unhealthy because that's the message that they're getting every day. At the same time, someone who is overweight or obese who has an eating disorder is less likely to seek treatment in fear of not being taken seriously or even in fear of being told that they need to lose weight, which is only going to exacerbate, obviously, the eating disorder. And I'm sure that we all have cases of those clients who do meet criteria for obesity, who've stopped engaging in really necessary health treatment altogether because they really don't want to go along and just be kind of given a lecture about their weight. So our obesity prevention approaches are not only ineffective and counterproductive, but they're harmful to the entire population. So what avenues do we have for change? I guess, as I started talking about in earlier slides, when we look at someone with an eating disorder, we have different subcategories, and we also look at what's going on for them medically and psychologically, and that informs treatment. So kind of bear with me if I kind of talk through what this might look like if we fleshed out a diagnosis of obesity in a bit more detail. So if we looked at someone with obesity and whether there really was any physical health implications and whether there was any psychological impairment and how we might, in early stages, start to look at that a little bit differently, that might be a bit more helpful and meaningful. So we know in the first instance we can have someone who presents with obesity who does have some sort of physical illness or disease but doesn't have any psychological impairment. So they're not distressed, they don't have an eating disorder, but they might have diabetes or heart disease or something like that. So to begin with, we might kind of regard that as obesity with physical health implications. In the next instance, we might have someone, again, who presents with obesity, but they have no physical health issue. And we know that not everybody who is obese has physical illness, disease, or impairment, but they might have some psychological distress. They might have an eating disorder, or they might have some sort of anxiety or depression. So to begin with, it might be more meaningful for us to even look at obesity with mental health implications. In the third instance, we can have someone who meets criteria for obesity and does have some physical health implications as well as some criteria for obesity and does have some physical health implications as well as some psychological implications. So obesity with physical and mental health implications. In the last instance, we can have someone who meets criteria for obesity but who is physically, metabolically healthy. They've got no disease or illness or physical impairment, nor do they have any psychological distress. They don't have an eating disorder and they're not distressed about their weight. And contrary to popular belief, these people actually really do exist. People, you don't necessarily have a physical or a mental health condition just because you meet criteria for obesity. So in this sense, obesity without physical or mental health implications. So this will obviously be a bit more meaningful and actually telling us something about what was going on for this person and where we might target our treatment, if any. But let's kind of take that one step further. So we know that we've got in the first category a bunch of people who have some sort of physical health problems. However, we also know that everybody of every weight, it can have some physical health illness, whether it's acute or chronic. So in the slides that I was looking at earlier, we know that nearly a quarter of people in a healthy weight range actually do have some physical impairment. So the obesity part of things is actually irrelevant. And what if simply we had just physical health conditions? So whether it's a lifestyle-related disease or non-communicable disease or whatever we want to call it, but just people who, regardless of their BMI and their weight, do have some physical health implications. We can start to do the same for the second category, because these people here have some psychological impairment, but no physical health impairment. And we know that psychological illness also occurs in every weight and shape and isn't actually dependent on size or BMI. So again, obesity, the term obesity in this subgroup of people is also irrelevant, and we just have mental health conditions. In the third category, what do we do with those people who are obese and have physical health impairments and psychological health impairments? We know that this also occurs at every shape and size and BMI category. So again, the obesity part actually doesn't add anything to our understanding of this person. So we just have comorbid physical and health conditions. Physical and mental health condition, sorry. So I suppose that leads us to, what do we do with those people who are meeting criteria for obesity and they have no physical health impairment, no illness, disease, abnormality, no impairment, disability in any way, and they have no psychological distress, no eating disorder? Well, those people are just well. They're medically and physically well. So I guess the conversation that I was really interested in starting today was, what does obesity actually really tell us? And instead of these obesity prevention campaigns that are more harmful than helpful, would we be better off moving towards lifestyle disease prevention, eating disorder prevention, mental health prevention? Or even, let's remember that health isn't just the absence of illness or disease. What about if we just had health promotion and we helped everybody of every size to be healthier physically and mentally? And I guess to kind of touch on it, if we remember as well, like the reason why we wanted people to lose weight to begin with was to help improve their physical health, to help improve their mental and social health, and to help improve their function. Weight loss itself was not the end point. It was simply the avenue that we've been told will lead to improvements in this area. However, I hope that you've kind of taken from today's presentation that one, that's not always the case, nor is it necessary. We can improve health in the absence of weight loss. And there's actually starting to become quite an exciting and encouraging whole body of research that is showing us that people can achieve clinically significant improvements physiologically, psychologically, and behaviorally in the absence of a weight loss focus and in the absence of weight loss itself. So mindful of running out of time. So I guess the last 2 points that I wanted to make is that, can we not just come back to making having a transdiagnostic approach to everybody of every size in targeting physical and mental health in everyone without getting hung up on this idea of obesity or BMI? And I was really, really excited and encouraged to see this position paper that's been released by the Academy of Eating Disorders when they talk about the approaches that we should be taking for obesity prevention and early intervention. And they also say a lot of the same things that I suppose I'm kind of advocating for, in that given the research and the evidence base, that approaches should be weight neutral and increase healthy living at all sizes. it shouldn't be marketed as obesity prevention, but rather health promotion. We should be paying as much attention to someone's social and emotional health as we do their physical health, promoting self-esteem and respect for body diversity, helping individuals feel comfortable and good about their bodies at every size, focusing only on modifiable behaviours. Weight loss is not a behaviour. So we can talk about helping someone to eat in a more healthy way or to be engaged in exercise in a more healthy way, but weight loss is not a behaviour. And let's shift the focus from just being about personal blame and responsibility and help create environments that foster social, physical, and mental health, or better health in all of those different areas. And they also say that, you know, these obesity prevention campaigns shouldn't actually target individuals specifically with segregated programs. It's not helpful to kind of pull out a subset of the population and say, you're going to have a specific intervention. And it shouldn't include language that has implicit or explicit anti-fat messages. And last but not least, weighing should not occur unless there is a clear and compelling need. And I suppose there are some really good guidelines around that as well. And I guess when we think about what's clear and compelling, going for an operation and needing to understand the dose of anesthetic required for someone, depending on their body weight, there's a clear and compelling need. Someone presenting with a flu or depression or an eating disorder, perhaps not so much clear and compelling. So I was trying to get really clear on what does someone's weight actually tell us. And we should be able to help everybody of every size be healthier in all of these different areas without it just being dependent on weight. So I didn't do such a great job of not getting on my milk cart. It was supposed to be a more objective facilitation, but as you can tell, it's a topic that I'm really quite passionate about. But now I'd like to hand back over to Susan and invite people to sort of make comments and to contribute.
Thank you so much, Kiera. Part of the problem, of course, for you is that it's such an important and large area, and to put it all into 45 minutes is quite a challenge.
Thank you.
Now, I have picked up a number of questions. I don't think we'll have time to address quite all of them, but I'll try and also pick out things that are perhaps most important. Now, one thing, there were a number of exceptionally interesting references or studies to which you referred, and there was one in particular that aroused both my interest and those people on the line about overweight people actually living longest, and I think you described it as a Lancet study. Mm-hmm. It would be fantastic if perhaps you could provide that reference to us, and then we can let the others know.
Yeah, absolutely.
Information on. And there was another reference, reference to metabolic change that I also found really interesting, because it seemed like it had also looked at participants in The Biggest Loser.
Yeah.
Is that seemed like it would be a very interesting study. I don't know if you'd like to make just a couple more comments about those papers whilst.
Yes, absolutely. I'm happy to provide a reference list of all of the studies that I've referenced in the talk, so I'll send that through with the PowerPoint slides. Yeah, the Biggest Loser one was really fascinating, and one that I did have a couple of slides on to talk about, but in sort of trying to keep to time, had to get rid of. But it's not the only study either that's looked at those changes metabolically and hormonally. But yeah, I'm happy to send along the reference, and people can have a bit more of a look over that and a read of that themselves.
Thank you. That would be fantastic. Now, there were a number of other questions. There was a bit of a discussion. People raised issues about bed, and I'm going to summarise the questions by saying, do have any other follow-up comments that you could make about binge eating disorder. There was some query online about where people with BED kind of fit in the statistics, how many people with obesity had BED and things of that sort. So I wondered if you'd just like to elaborate a little bit on binge eating disorder and the interface and connections.
Yeah, absolutely. So we know that that there can be some overlap and correlation between people with binge eating disorder being at a higher risk of being overweight and obese, and people who are overweight and obese being at a higher risk of binge eating behaviour. However, we also know that binge eating disorder doesn't occur exclusively in those who are obese or even overweight. So it can occur across the weight spectrum. So we can have people in normal and low weight who also experience binge eating disorder. And I guess I didn't quote any particular statistics around the number, so I guess there is an overlap, but we can't say that that binge eating disorder occurs only exclusively in those who are overweight or obese. Again, it's something that can occur in healthy and low weights as well.
Right.
Cool. Does that sort of speak to the question?
Yes, I think so. Thank you very much. And Fiona Sutherland has just posted a question. She's saying that she's working in the field of eating disorders. I'm seeing increasing numbers of people with following bariatric surgery. I'd love to know your thoughts about the place of bariatric surgery in all of this. Thank you.
Thanks, Fiona. So when I did actually start to look at bariatric surgery, and I could find low levels of effectiveness with banding. So we know that at 5-year follow-up, that banding isn't any more effective than behavioural weight loss. I actually couldn't find a lot of information on sleeving because I guess it's relatively new and there hasn't been as much research in this field. And I'll try and keep my views on this as diplomatic as possible. But I also do see in clinical practice a lot of people presenting with banding or sleeving who have had to remove the band and who have lost significant amounts of weight that's led to malnourishment and even triggered off an eating disorder. And I know a particular medical doctor who works here in Brisbane talks about a caseload of clients that she has who have gone on to develop anorexia post bariatric surgery. So yeah, I guess we don't know enough about the sleeving, but the banding has been shown to be ineffective as well as have a whole host of negative implications associated with it.
Thank you. That's really important. I'm sorry to the other Fiona, whose name I can't catch. Sorry about that. There's another Fiona on the line, so it wasn't Fiona Sutherland. Look, we're going to have to wrap up in just a moment, but this is a really important area, and I just do want to highlight that at our conference coming up in Sydney, actually it's very beginning of September, we have a plenary on this area, and it's a really, thank you, Jeremy, it's a really important area. So the plenary, Eating Disorders and Obesity, Connections and Controversies, raises a number of the issues that you've raised, Kiera, and there are the speakers, Sue Byrne, Fiona Willer, Evelyn Smith and Liz Rieger, are all important contributors to this area, and so I highly recommend this topic for people who have an interest in this area. It's so important. I have a whole lot of other questions I would have liked to have asked you, and I think I'm going to follow up a bit later. So I'm just going to put on the record that I'd love to know some of the gender issues that are coming up in this interface area. So I'm going to be following up with you about that and a number of other questions.
Happy to.
Thank you. But I do want to thank you again, Kiera, for a fascinating talk, and it's so well researched. And the slides will be available, and in fact, the whole webinar will be available on our members' website in a little bit. So people can listen to it again, and it was a fascinating presentation, and I really appreciate your the work that's obviously gone into putting this together in such an informative and helpful way, not to mention challenging some of our ways of thinking. So thank you very much, and thank you to our online audience. And I'll close there. Goodbye.
Thank you.